All right, let's dive deep into the modern management of migraine. If you're getting ready for your anesthesia finals, this is the detailed evidence-based review you've been looking for. We're going to break down everything you need to know from the absolute basics all the way to the newest therapies. Let's get into it. So here's how we're going to break this down. First, we'll get a quick overview just to understand the scale of the problem. Then we'll jump right into tackling acute attacks, followed by the strategies for preventing them in the first place. After that, we'll explore the really advanced stuff for the toughest cases, and we'll wrap it all up with some key things to remember, like managing migraine during pregnancy. So, first things first, why is it so critical for you, especially in anesthesia and pain management, to have a really deep understanding of migraine? Well, let's just look at the numbers. And the sheer scale of this is, well, it's staggering. Migraine affects a huge 15% of the general population. And get this, it's 3 times more common in women than in men. It's also a leading reason people end up in the hospital with acute neurological issues. So let's be clear, this is not just a bad headache. It's a major public health condition. Okay, now that we've got the big picture, let's get into the nitty-gritty. Let's talk about the clinical challenge you're going to face most often, managing the acute migraine attack itself. Okay, this slide is super important because it shows the 2 main ways we think about prescribing. On one hand, you've got the traditional stepwise approach. Start simple, see if it works, and move up if it doesn't. But look to the right. The stratified approach is really where modern practice is at. You actually tailor the initial treatment to how severe the attack is from the get-go. And the evidence is clear, this works better and it's more cost-effective. This is a crucial concept. For those mild to moderate attacks, our go-to options are the simple NSAIDs like ibuprofen and naproxen, or just paracetamol. But here's a key clinical pearl for you. Add an antiemetic like metoclopramide. Even if the patient doesn't feel nauseous, it actually helps the painkiller get absorbed better and just makes it work more effectively. Now, when things get more serious, we're talking moderate to severe attacks, we step up our game. The mainstays here are the triptans, which are serotonin 5-HT1 receptor agonists. But the new kids on the block you really need to know about are the gepants, like rimegepant. These guys are CGRP receptor antagonists. CGRP, that's calcitonin gene-related peptide, is a key protein that drives migraine pain, and blocking it is a game changer for patients who don't get relief from triptans. Okay. This next point is one of the most important things you will tell your patients. You absolutely have to get this across. We've got to worry about medication overuse headache, or MOH. Basically, if you use these acute meds too often, you can actually cause more headaches. And almost everything we use carries this risk, with one big exception, the new CGRP antagonists. So the advice for patients is a hard and fast rule. Do not use acute treatments for more than 2 days a week. Now, let's talk about a true medical emergency. Status migrainosus. This isn't just a bad migraine. This is a severe, relentless attack that goes on for more than 72 hours. It's a huge problem, accounting for up to 10% of all acute hospital admissions for headache. And that's often because the person is just so severely dehydrated. And this slide lays out the in-hospital game plan perfectly. Step 1, always, is aggressive rehydration with IV fluids. Next up, in Step 2, we hit them with IV antiemetics. Step 3 is IV pain relief like ketorolac. And for those really stubborn cases that just won't break, Step 4 shows us our escalation options, IV magnesium, sodium valproate, or a shot of dexamethasone to finally break that pain cycle. All right, so we've covered putting out the fires, those acute attacks. Now, let's shift gears and talk about the long game, prevention. How do we reduce how often these attacks happen, how bad they are, and how long they last? So, this begs the question, right? Who actually needs to be on preventative therapy? I mean, it's not for every single patient, but for the right person, it can be absolutely life-changing. So who are we talking about here? Well, the main indicator is frequency. Anyone with 4 or more headache days a month is a candidate. We also look at it for patients when their acute treatments just aren't cutting it, or maybe they can't take them for some reason. And for a few specific subtypes, like hemiplegic migraine, we think about it even if the attacks are less frequent. And listen, the goal here is ambitious. We are shooting for at least a 50% reduction in headache days. These are your first-line workhorses for prevention. As you can see, the options come from a bunch of different drug classes, beta blockers like propranolol, antidepressants like amitriptyline, ARBs like candesartan, and anticonvulsants like topiramate. The mantra you have to remember when prescribing these is start low and go slow. You begin with a tiny dose, and you slowly titrate up over 6 to 8 weeks to find that perfect balance between benefit and side effects. But what happens when those tried and true options just don't work? Well, that's when we bring out the big guns. This is the new cutting-edge arsenal for treatment-refractory migraine. These advanced treatments really fall into 4 main buckets. We've got injectables, we have peripheral nerve blocks, which are super relevant for anesthesiologists. We've got new oral drugs like those G-PANTs we talked about, and finally, these amazing non-invasive neuromodulation devices. Okay, so let's compare the 2 main injectable options, because they're quite different. On the one hand, you have anabotulinum toxin A, which you probably know as Botox. This is only for chronic migraine. That's 15 or more headache days a month. On the other hand, you have the CGRP monoclonal antibodies. These can be used for both episodic and chronic cases. They're self-administered injections that directly go after that CGRP pathway we talked about earlier. This table is a fantastic summary of the advanced options that NICE recommends for patients who've already tried and failed at least 3 of those first-line oral treatments. You can see the injectables we just discussed, plus the new oral CGRP antagonists, atogepant and remigepant, which give patients a daily or every other day pill option for prevention. Now, this is where things get really interesting, a non-drug approach. Neuromodulation devices offer a totally different way to tackle this by modifying the body's neural circuits. We've got options like single-pulse transcranial magnetic stimulation or devices like Cephaly that stimulate the trigeminal nerve. The cool part is, these can be used for both treating an acute attack and for prevention, giving patients a powerful option without any medication. All right, let's start to bring this all together. We're going to tackle a super important special population, pregnant patients. And then we'll summarize the core principles of migraine management that you absolutely need to know for your exams. Okay, managing migraines in pregnant or lactating patients. You have to be extra careful here. The good news? About 2/3 of women find their migraines actually get better during pregnancy. If you do need to treat an acute attack, paracetamol and sumatriptan are considered safe. NSAIDs are okay too, but you must stop them by 32 weeks. For prevention, low-dose amitriptyline and propranolol are generally safe. But here's the critical takeaway. All the new CGRP drugs are a no-go. We just don't have the safety data. So to wrap it all up, effective management is really a holistic process. It's a combination of strategies, as you can see here. It all starts with lifestyle. Then you need a clear, stratified plan for acute attacks. You need to be proactive about offering preventive therapy to anyone with 4 or more headache days a month. And for those really tough cases, you now have this powerful toolkit of advanced therapies to fall back on. And that leaves us with a really interesting question to think about for the future. As these new, highly targeted and really well-tolerated CGRP therapies become more common, what does that mean for the old workhorses like beta blockers and antidepressants? Will they eventually just become obsolete? It's something to think about. Just so you know, all the evidence-based information we've discussed today comes from the 2026 article in BJA Education titled Migraine Part 2, Evidence-Based Acute and Preventative Treatment by Khan, Zinnias, and Ahmed. Thanks so much for joining me.